All right, let's dive right into this explainer. We're going to uncover the rare and frankly deeply fascinating ways tuberculosis can actually invade the central nervous system. Now, we all know the classic pulmonary pathology, the lung stuff. But when TB reaches the brain, it creates these incredibly complex, life-threatening scenarios that demand absolute precision in medical management. And today, we are not skipping a single detail. We're going to look closely at the precise mechanisms of these rare neurological manifestations. To make sure we don't miss anything, we're breaking this down categorically into 3 specific rare manifestations: TB brain abscess, TB vasculopathy, and TB encephalopathy. Let's get right to it.
Starting off with Section 1, the TB brain abscess. This is a distinct, much rarer phenomenon compared to your standard tuberculoma.
By definition, we're looking at something that requires highly specific clinical attention. You see, while a tuberculoma is basically a solid mass of inflammatory tissue, a TB brain abscess is an actual accumulation of pus right there in the brain tissue. It's a vital distinction, mainly because it completely alters how the mass behaves physically and, as you'll see, how it appears on neuroimaging.
What's absolutely crucial here is the physical size. These abscesses tend to be significantly larger, usually measuring greater than 3 centimeters. Imagine a mass of that size taking up space inside the cranial vault. It naturally compresses the surrounding brain structures, which leads us directly into the clinical reality of how the patient is actually going to present.
If a patient has this, they're typically going to present with 3 very distinct clinical signs. First, fever. That's your classic systemic marker of an ongoing infection. Second, a severe headache, which makes total sense given that 3-centimeter-plus mass is actively driving up their intracranial pressure. And finally, a focal neurologic deficit. This means a specific loss of function, maybe weakness in an arm, or sudden difficulty speaking, and that happens exactly because of where that specific abscess is compressing functional brain tissue.
Now check out the severe risk disparity across patient populations. Immunocompromised individuals face a massive 20% prevalence rate. Compare that to just 4 to 7.5% in patients with healthy immune systems. That is a massive leap in risk. So you might be wondering, why exactly does this happen?
Well, the reason for that stark 20% figure boils down to cellular defense. Immunocompromised patients simply lack the ability to form protective granulomas. Think of a granuloma as the immune system's way of building a wall around an invading pathogen. Without that crucial defense mechanism, the TB bacteria just run rampant, breaking down tissue and forming these large, pus-filled abscesses instead.
So how do we actually spot it radiologically? It's kind of tricky. On standard CT and MRI, a TB abscess looks frustratingly similar to a regular bacterial or pyogenic abscess. But here's where it gets interesting. DWI-MRI becomes our absolute key tool here. Diffusion-weighted imaging demonstrates restricted diffusion inside the mass. That specific feature is exactly what helps radiologists confidently distinguish a TB abscess from a standard solid tuberculoma.
When it comes to actually fighting this, anti-tubercular therapy, or ATT, is our frontline defense. It's the absolute cornerstone of management. Before we even think about going in surgically, we have to hit the underlying infection with a rigorous, aggressive course of ATT.
But if the patient doesn't respond to the ATT, we have to escalate to surgery. And we don't just jump to the most invasive option right away. It's a step-by-step process. First up, stereotactic one-time drainage, which is basically a highly targeted needle aspiration. If that's not enough to clear the pus, continuous drainage might be set up. Sometimes doctors even have to do repeat aspirations, going in multiple times. Finally, as an absolute last resort, we're looking at total excision, completely removing the abscess surgically.
Moving right along to Section 2, let's see how this pathogen targets the vascular system with TB vasculopathy.
This condition is almost always a downstream consequence, a sequela of TB meningitis. Very rarely will it strike without prior neuro-TB. Essentially, the profound inflammation from the meninges literally spills over and violently attacks the blood vessels of the brain.
Infections can cause vasculitis in a few ways, but in neuro-TB, the attack happens through 3 exact mechanisms. We're going to break these down one by one so we can fully grasp the microscopic warfare happening directly in the brain's blood supply.
Looking at step 1, direct invasion. This specifically targets the circle of Willis, the thick,
inflammatory basal exudates, which are basically a toxic sludge created by the infection at the base of the brain, physically inflame the blood vessels. This leads to stenosis, a dangerous narrowing of the vessel opening, and eventually severe thrombus or clot formation.
Then, in step 2, the damage shifts to being immune-mediated. Tubercular protein immune complexes stubbornly deposit themselves directly into the walls of the small vessels. Your own immune response to the TB proteins ends up triggering severe inflammation inside the vascular architecture itself. And to make matters worse, as a third mechanism, the body might even form antibodies against its own host antigens, creating a devastating autoimmune loop.
Because of these blocked, narrowed, and highly inflamed vessels, the clinical presentation is sudden and frankly terrifying. We're talking stroke-like events. The blood supply to a specific part of the brain gets completely cut off, and the patient experiences sudden neurological deficits that mimic an acute stroke perfectly.
So the crucial point for management here is speed, catching this vascular compromise fast. We rely heavily on MRA, or magnetic resonance angiography, to show that basal meningeal enhancement alongside those desperately narrowed vessels. At the same time, DWI-MRI is incredibly useful for spotting early infarction, basically early tissue death. And because this pathology is fundamentally driven by extreme inflammation, corticosteroids are your absolute mainstay for treatment to bring that swelling down.
Finally, we arrive at our third condition, Section 3, TB encephalopathy. This is a severe, widespread central nervous system involvement that operates completely differently from the localized abscesses and vasculopathy we just talked about.
This specific variation is both tragic and unique because it primarily occurs in the pediatric population. It's a rare form of central nervous system involvement for sure, but when it does strike, it overwhelmingly targets children.
A child suffering from TB encephalopathy will present with some truly devastating neurological markers. We're not just looking at one isolated sign here. They might have a severely altered level of consciousness, slipping into a stupor or even a coma. You'll often see debilitating seizures and involuntary movements, which can progress all the way to outright paralysis. Alongside all that, cerebellar signs emerge, completely disrupting their balance and coordination.
So, what on earth causes this massive brain-wide dysfunction? Medical science is torn between two primary theories. Theory 1 suggests it's a delayed type 4 hypersensitivity reaction to a TB protein that's actually located somewhere else in the body. Essentially, the brain's immune system wildly overreacts to a distant threat. Theory 2, on the other hand, argues that the encephalopathy stems from hypoxic ischemic damage, meaning a systemic lack of oxygen and blood flow, or toxic complications paired with extreme electrolyte imbalances.
When we take a look at the MRI, the findings outline severe, widespread damage. We see diffuse cerebral involvement, meaning the entire brain is reacting, not just one localized spot. There's extensive white matter edema, or swelling. But most importantly, we see marked gadolinium enhancement. This specific enhancement is critical because it proves active demyelination is happening. The protective myelin coating of the brain's nerve fibers is actually being stripped away.
Now, unlike the strict, clear-cut surgical protocols we discuss for abscesses, management here is a bit less definitive. However, a combination of steroids and ATT may offer some real clinical help. We are fighting a massive, system-wide inflammatory response in the brain, so tamping down that runaway immune reaction with steroids while actively killing the bacteria with ATT is absolutely our best clinical hope.
So, considering the devastating stroke-like impacts, the widespread demyelination, and the rare abscesses we've explored today, it really leaves us wondering, as our diagnostic technology continues to evolve, how might we intercept these specific TB variations before they even reach the nervous system? Because truly, understanding these microscopic structures is the very first step toward outsmarting them.